So welcome back to the TRT and Hormone Optimization YouTube channel. And back with us as a guest is Dr. Rudy. Welcome back, Rudy.
Thank you, Stephen. Thank you, Dr. Devos. Again, excited to be here. Really enjoy our talks every time we have this. So thank you for inviting me again.
Thank you for your time. So today, let's talk about the new class of weight loss drugs. They are very popular as well in the United States, as well here in Europe too. And we hear a lot of Ozempic and Mounjaro. So maybe give your experience with them.
Definitely. So this is the most exciting development that has happened in medicine in a long time. So I've had a weight clinic. I started a weight loss clinic in Miami, me and my wife, 17 years ago. And again, I've gone from acute medicine, where I was a hospitalist working in the hospital, to now going into more preventive medicine with my weight loss clinic. And what we always had as far as weight loss medication were always stimulant-based medication. Things like phentermine, diethylpropion, all of those, they are usually norepinephrine reuptake inhibitors, work in the brain, control appetite by neurotransmitters. For example, phentermine has been FDA approved in the United States since the 50s. So there hadn't been any new weight loss medication for a long time that were very successful. So, and the type of stimulant medication like phentermine tend to have a good amount of side effects, increasing blood pressure, insomnia, severe constipation. So, but no matter what, those were the tools we used to have. Now, there's been a new development of that new class of medication called GLP-1 receptor agonist, which stands for glucagon-like peptide 1 receptor agonist. And people think those are new medications, but they are not. Actually, we've been using, and I've been using those medications for a long time for diabetes treatment. So since 2005, they came out, and they were a different way of treating diabetes. For example, I work as a primary care physician in the Miami area with a Native American tribe, and they have a lot of diabetes. And when I started working there, I realized that their diabetes was mostly because of insulin resistance and obesity. So I switched most of those patients from insulin to GLP-1 agonists to decrease weight and decrease insulin resistance. And we had amazing effects. So I've been using those medications for 10 plus years in my diabetic patients. But every new generation of those GLP-1 agonists that came out became better. So in 2014, there was one called Saxenda that became FDA approved for weight loss without needing to have diabetes. Because those medications, people misunderstand. Those are not really diabetes medications. They are medications that work on what they call incretin hormones, which I'm going to go over, and have a beneficial effect on weight, but also on blood sugar. So they are not just diabetic medication. We've been using them for that. So Saxenda came out in 2014, and it got FDA approval for weight loss, even if you don't have diabetes. It was a decent medication. I used it quite often, but it wasn't amazing. Then in 2017, the newer generation GLP-1 came out, Semaglutide or Ozempic. And it did amazing, not only to help control blood sugar, but to help with weight loss. It did so well with weight loss that it became FDA approved for weight loss, even if you don't have diabetes, under the brand name Wegovy. And I used to love semaglutide. So again, for your viewers, they have to realize semaglutide is a generic name that has two different brand names, Ozempic and Wegovy, but it's the exact same medication. It's like using acetaminophen versus Tylenol. So it is the exact same. So I've used semaglutide for a long time because it worked. And then Mounjaro, the new one, Tirzepatide, came out in May. And that changed the landscape completely. So let me go back and explain what is a GLP-1 agonist exactly. So GLP-1 agonists, they target what we call incretin hormones. Incretin hormones are found in the gut, and they're responsible for many things. One of the main things is that it helps increase the amount of insulin that is released when we take food orally, when we take glucose. So if you give somebody glucose, the same dose of glucose intravenously versus orally, you'll see that the oral dose will induce a higher response of our insulin curve. So this is the incretin effect. It's kind of a complicated thing to understand. I have to read a lot about it to really understand it. But basically what the incretin hormones do, when you take glucose by mouth, you get a higher response from your insulin. So you get to the glucose to go into the muscles quicker. So again, science is amazing. The researchers were able to isolate those receptors, and they've been using those to help exactly with the insulin release. And they found out that besides just the insulin release, there's a lot of other things that it does. GLP-1 receptors are also found in the brain in the areas that help with satiety and appetite control. So when you take that, you tend to be more satisfied with food, you eat less, and you're satisfied. And when you talk to people who are trying to lose weight, it's always that same thing. Most people know now what they should do to lose weight, right? They know their macros, they know what they should do. They could write a book. Most of my patients tell me, Doc, I could write a diet book. I know so much about it. But put me on a weeknight, on a weekend where I'm with my friends or I'm stressed, everything goes up and I start eating bad. And each one of us, we have our little weaknesses. There's people who are sugar people. There's people who are carbs. There's people they snack too much. There's people who they have one chocolate and then the whole week gets bad. So we think about it as willpower, right? When somebody cannot control their eating, you need to have to get more willpower. You need to really help with this. And now we're discovering willpower is really a chemical reaction. So once now we gave those patients those agonists, those GLP-1 receptors, we saw their willpower became stronger. So now they could do what they knew they were supposed to do. So this is the magic of those medications. It works in different ways. First, it works in the brain to really increase satiety, decrease appetite, and then it works in the gut to really increase our response of insulin to get the sugar into the liver and into the muscles. And it does something else also. It decreases the release of glucose from the liver, gluconeogenesis. So it really attacks our metabolism from different ways. So again, now I'm going back to, I started using semaglutide, which is Ozempic or Wegovy, and we're getting amazing results. Then came Mounjaro or Tirzepatide. So all of those previous medications were only affecting one receptor of the incretin hormone, which was GLP-1. Now, Mounjaro also targets a second incretin hormone called GIP, glucose-dependent insulinotropic polypeptide. That's a mouthful. But it is another incretin hormone. Now, Tirzepatide is the only one in that class that can affect both receptors. And what's important with the GIP receptor is that it does a lot of other things in synergy with the GLP-1. So you get more insulin release, you get more satisfaction, more satiety from your food. And one thing that's important from the GIP, which I only found out once I started researching that, GIP receptors are very abundant in fat cells, whereas there are no GLP-1 receptors in fat cells. So now the GLP-1 GIP combination, not only do you have the appetite control, the increased insulin release, but the GIP receptor, because it's in the fat, it induces lipolysis and fat oxidation much more. Also, even decreases triglycerides and improves lipid profile. So that is amazing. So I've always said that. I loved semaglutide. I adore Tirzepatide. Semaglutide was great. Tirzepatide is amazing. Again, it's because of that combination, the second receptor that they added to it. So what can somebody expect when they take those medications? So both GLP-1, they are the same type. They're usually injected once a week, and there's a ramp up of the medication, meaning you start at the lower dose, and then after 4 weeks, you go to the higher dose, and you find what the dose that works for you. So you ramp up the dose. And this is done like this to try to decrease side effects. Now, I'm going to say those medications are great, but they do have side effects. And you want to be sure that you talk to a provider that is experienced, can explain all this to you, and even help you deal with some of the side effects better. So because GLP-1 agonists tend to slow down digestion, that's one of the ways that they decrease appetite. The rate of transit of the food from the stomach into the intestine decreases. So a lot of patients, the way it decreases appetite is that you feel full. The food is not moving. So I tell patients will tell me that they're like, oh, when I take those medications, food is right here. That is my sign when somebody's on semaglutide or tirzepatide. I'm like, how are you feeling? They're like, right here. The food feels right here. You know, Stephen, has that happened to you when you overeat at a party one day? And you're like, oh,
Yeah.
one more bite. The food is right
Yeah, you just feel it. Yeah.
So it can be an uncomfortable feeling. It can be a nauseous type feeling, but that takes away your appetite. So most people, because the half-life of the medication is about 5 to 7 days. So you tend to get more of that nauseous feeling, the I'm almost too full feeling, the first 2 to 3 days after the injection. And then usually your body gets used to it. I've definitely had patients who had vomiting while taking that, especially if they don't eat the right things. So that can happen. So what I counsel my patients about when they take those medications, make sure that they try to eat as lean as possible. Because the higher the fat content, the higher the sugar content of those foods, the food tends to be stuck here more. So people will learn, and each person is different. They will learn what kind of works for them, what they can eat and feel good. And again, semaglutide side effects, in my experience, and even in some of the studies, tends to be higher than the tirzepatide. So I see fewer side effects with it. And we tend to ramp up a little slower with the tirzepatide versus the semaglutide. So we've been getting amazing results with those medications. And I know in Europe, semaglutide or Ozempic is available. I'm not sure if Mounjaro is already available.
Not yet, not yet.
It's pretty recent. And one important thing, tirzepatide or Mounjaro did not get FDA approval for weight loss without diabetes yet. The studies are ongoing. They should be ready by the end, mid of next year. But we know it's a class effect. And the results really are even better. They actually did a study where they compared head-to-head patients on semaglutide versus patients on tirzepatide. And they saw, I think the study was about 60-something weeks. So the patients stayed on it long-term. Patients on semaglutide were able to achieve about 12 to up to 15% of body weight loss, which is pretty amazing. So if you weigh 200 pounds, you can lose 20 to 30 pounds with those medications. With tirzepatide, they got almost up to 20%, which is amazing. Gastric sleeve surgery or bypass usually can induce maybe 25 to 30% weight loss. So now they're saying that tirzepatide for the selected patients can be as good as gastric bypass surgery. How amazing is this, right? So you don't need to do this very invasive procedure, and you can have a way to really get the same results. And what's important, most of those studies were done where those patients were not even given a diet. They were not optimized on hormones. They just told them, take those medications and they got this. At my clinic, we get even better results because we have a nutritionist that we assign to our patients. We balance their hormones. So we get even better results. It's crazy. I get patients, again, weight loss to me, it's not just about the number of pounds you lose. It is about the metabolic improvement that you get, the insulin sensitivity that increases, the decrease in visceral adipose tissue that happens. So all of those things are amazing. Of course, for us doctors, we get excited about the metabolic improvement and health improvement. But the patients, when they lose 20, 25 pounds, they can, their waist size is going down. They can start wearing the clothes they had put in the back of the closet. This is an amazing thing. And I always say that weight loss is the biggest motivator. You could give me a patient that's been trying to lose weight, typical, you lose 2 to 3 pounds, gain it back over the weekend, and kind of goes around like this. If I get a patient in the first month, they lose 6 pounds, they lose 10 pounds, their clothes are fitting better. You know what? Their behavior changes. Now they start doing the things they knew they were supposed to be doing. They start having better willpower. They start exercising more because they feel better. And now they hope they can see themselves really losing the weight in the future. And I take advantage of that a lot. I tell patients, visualize yourself. We finally got something that can get you to your goal. So it's been amazing. Again, I like to temper this with the side effect profile. So, I counsel patients for a long time about this because patients have to realize every medication has side effects. So the GLP-1 medication, I said already, nausea and vomiting, constipation, sometimes diarrhea, acid reflux, and those are the main side effects. But again, the discontinuation rate in most studies was about 5%. So really not many patients. And the way I deal with it is I tell patients what they should eat the day, 1 or 2 days after. They can have hot tea, ginger tea if they feel nauseous. There's different things that we can do to help mitigate that. So besides those adverse reactions, there's also some side effects we need to talk about. So there's a possibility of acute pancreatitis with those medications also, which I'm always careful about. And I always take the history. If a patient has had acute pancreatitis before, it's not a good idea to go on those medications. The earlier generation, GLP-1s, I used to see more. I've had a couple of patients who actually went to the hospital with acute pancreatitis. So it is something we need to take seriously. The newer generation, I haven't seen much at all. So it is still a theoretical possibility, but the incidence is way less. Another thing people talk a lot about, and it is a black box warning on those medications, is that in mice and rat studies, they showed that there was a slight increase in a specific form of thyroid cancer called medullary thyroid cancer, not the typical follicular. So if you look at that medication, there is a black box warning that this may increase the risk of thyroid cancer by that particular type. So I've never seen a patient with this. So one thing is, if the patient has a family history of MEN, multiple endocrine neoplasia type 2, they should not take those medications. Stephen, I've been doing this for more than 20 years. I've asked every patient. I've never met one person yet with a family history of MEN type 2. So we need to be aware of this, but it's something that's very rare. So now that we've seen the possible side effects and the contraindication and the black box warning, so I do an informed consent with my patient. We review the side effects, we review the risk and benefits, and then we decide, and I'm going to tell you, 99% of patients, after they see the studies, they decide to go forward with the medication. Because again, what's important for me? Those are new medication. They've been out more than 12 years. So if significant side effects would have developed, those millions of people who have been taking GLP-1 agonists over the past 10, 12 plus years, we would have seen it. I don't like prescribing, especially weight loss medications when they first come out, because 3 to 5 years after FDA approval, that's when things tend to go south. As an example, Meridia, which was a very hyped up weight loss medication, came out in the early 2010s. I never used it. It came out with a lot of hype, was really doing well. Within 5 years, they found out it was causing increased risk of cardiovascular disease, so it got recalled. So I want to wait a minimum of 5 years when a new medication comes out before I start using it, especially for weight loss. It's okay to wait. Now we have enough experience with the GLP-1 medication. We know that the benefits completely outweigh the risk.
Another question, what are the typical doses or dosage schemes you give to patients?
So each formulation, each brand will have their own dosage. For example, Semaglutide or Ozempic, they will start at the lower dose, 0.25 milligram once a week. For 4 weeks, then you increase to 0.5 milligram. And for Semaglutide, you can go all the way up to 2.4 milligram. For Tirzepatide or Mounjaro, you start at 2.5 milligram once a week for 4 weeks, then you go up to 5 milligram, and you can go up to 15 milligrams. In Tirzepatide, it is so effective that most patients stay at about the 5 milligram range. And I'm going to tell you with Tirzepatide, because again, the GIP, like I said before, does act on the fat cells for lipolysis and fat oxidation. I've had patients who call me, they're like, Doc, the Mounjaro is not working that well anymore. I'm starting to feel a little hungry. I'm like, just stay with it. Even if you eat a little more, it's okay. They call me 2 to 3 weeks later. My pins are falling off. I'm losing fat, even if my weight is not changing. So those medications have benefits way beyond just the number of pounds you're losing on the scale. And we see that also. A lot of my patients will come to me and they're like, I lost 10 pounds. But my clothes, I lost 2 sizes in my clothes because you lose so much fat. Even in the face, you see people, it's like a fat transformation that we see a lot more with Mounjaro. So to answer the question again, each brand will have a specific dosage that we follow. But what's been amazing in the United States is that the compounding pharmacies were able to get those chemical formulas, Semaglutide and Tirzepatide, and they added B12 to it. Once you add a different compound to a chemical formula, it's no longer under patent. So the compounding pharmacies in the US made it available for us functional medicine docs that we have the generic name. Again, it is not Mounjaro, they call it Tirzepatide plus. It's Tirzepatide plus B12, Semaglutide plus B12. So as an example, I had a patient on Tirzepatide that was having side effect at the lowest suggested dose, 2.5 milligrams. What I did, I made her, so she was having a lot of vomiting. I told her, stop the medication, let 2 or 3 weeks, let the medication wash out, and I restarted it at the lower dose, 1 milligram a week. And she's doing amazing. That patient was 72 years old. She lost 28 pounds in 3 months. She could never lose weight. So that's amazing. And that's what we can do with the generic version from the compounding, because we can alter the dosing. Whereas the brand name come with a pen, and you can only do the pens that are already pre-selected. So the pens are much easier with injection. They make it easy for you. But I like the flexibility I have with the generic version where I can alter the dosing.
Yeah, that's amazing. Yeah, I'm hearing from patients here as well in Europe that they are having great results with Ozempic already. So I'm looking forward to the on the market bringing of the Mounjaro as well. So I'm very curious for that. So,
Definitely. So another thing, for example, Ozempic, and those are class effect, but Ozempic has an amazing study. I think it's called the Sustain 6, where they even show that patients who take diabetic patients or patients with metabolic syndrome, pre-diabetes, have a high risk of cardiovascular disease. So they showed that patients on Ozempic actually have lower risk of heart disease. So cardiologists are starting to prescribe that medication. How amazing is this? Not only are you going to lose weight, your diabetes is going to get better, but your heart is going to get protected. And if I compare that to the older appetite suppressants like phentermine, who are always worried about cardiovascular side effects, whereas those new medications actually protect your heart. So this is a win-win. There's another thing I want to address. A lot of people, when you talk about those medications, they have a negative view of weight loss doctors talking about this, because there's unfortunately a shortage of the brand name of Mounjaro, Ozempic, and Wegovy, because a lot of people even pay out-of-pocket expense, which is almost $1,500 for the brand name, and people are using it for weight loss. So diabetics sometimes cannot get it through their insurance, and they're saying that we should not promote it, that it is a diabetes medication. It is not just a diabetes medication. It's a metabolic improvement medication. Actually, what it does best is that it improves your metabolism, it improves your lipids, it decreases your appetite, helps you decrease weight, and helps you decrease VAT, that visceral belly fat. By doing all this, you get better diabetic results, you get better blood sugar results. So it's not just a diabetes medication, it's a medication that does amazing with our metabolism and helps with diabetes, weight loss, and even cardiovascular disease. And for the diabetic patients, if they cannot find Ozempic or Tirzepatide, they can still use the older GLP-1 like Trulicity, Saxenda, Bydureon. I have amazing results with my diabetic patients who cannot find Ozempic with the other one. And in the United States, the insurance does cover all of the older GLP-1s also. So the big question is, who should get those amazing medications? To me, everybody who has excess belly fat, excess weight, pre-metabolic condition like fatty liver, pre-diabetes, metabolic syndrome, all the way to diabetes and cardiovascular disease, all of those patients should be on those medications. What I'm hoping is that it's going to become more available and insurance is going to cover it more, so that there's not a rationing of those medications.
Looks very promising. So thank you very much for explaining. I think that this will motivate a lot of people to contact their doctor and talk about this.
Definitely.
Thank you so much.
One other thing I wanted to talk about, it's treatment of diabetes, prediabetes, and metabolic syndrome with a combination of either semaglutide or tirzepatide with testosterone. So patients who have diabetes or prediabetes, there's about a 30 to 40% chance of those patients having low testosterone. There's a bidirectional relationship between diabetes and low T, because we know that patients with diabetes, studies are very strong about this, 30 to 40% of them have low T, and patients with low T, about 30% to 40% of them have prediabetes or diabetes. So when I get patients coming to me with either diabetes, prediabetes, or the metabolic syndrome, we always check their testosterone. If their testosterone is not where they're supposed to be, having the combination of testosterone plus one of those GLP-1, either semaglutide or tirzepatide together, it is the stacking of choice for those patients. Let me give you an example. He was actually a friend of mine, and he was referred to me by his endocrinologist he was a diabetic, not well controlled, and he was labeled non-compliant. He was only on metformin. His A1C was 10 plus. The endocrinologist called me kind of frustrated. This patient, I tell him he needs to work out. He needs to, he needs to eat less. He's not following. When I spoke to him, the patient was like, "Doc, I try to work out. I'm exhausted. I go and work out. I hurt for 3 to 4 days. I have no motivation, no energy. When I checked his testosterone levels, testosterone was 380. Again, that kind of red zone, the free testosterone was 8. Remember, free testosterone normally is 7 to 25. So it was lower limit of normal, did not cross the red line. So I called that combination T square, Tirzepatide plus testosterone. 4 months later, patient lost 30 pounds. His A1C went from 10 to 7.6. He has energy. He built muscle. He's no longer a non-compliant diabetic. So we address the root cause of his problem by optimizing his hormones and helping him control his appetite, decreasing his visceral fat, and he has amazing results. So if anybody in here is listening, somebody has diabetes, pre-diabetes, or metabolic syndrome, make sure your doctor checks your testosterone. And if needed, the combination of testosterone with and Ozempic works very well. One of the Tide, I call them Tide, weekly Tides, Semaglutide, Tirzepatide, Exenatide. So those are weekly Tide medication. So testosterone plus a Tide medication should be the standard of care to treat diabetics with hypogonadism. Believe me, as a patient, you'll see an amazing result. And as a provider, we should do that more because we empower patients into getting better results and better health.
Awesome. Thank you so much for explaining, Dr. Rudy. Thank you.
My pleasure.
And now, click on this video to learn more about TRT and hormone optimization.